Okay, welcome back, guys. So we'll continue with the neuro questions. Continuing along here, I wanted to include something on the homunculus and the concept of how that helps us understand the stroke symptoms and the middle cerebral artery, the posterior cerebral artery, and the anterior cerebral artery, and how we can just use this homunculus to easily understand that. So the question is, explain the homunculus and how it can help us understand the stroke symptoms. So the homunculus is a basically body representation across the brain here. And as you can see in the picture, the feet, you can picture it as like somebody dangling their feet over into the water here, which is the middle. So the feet are down in the middle here, which is going to be occupied by the anterior cerebral artery. And the face is out to the side. One is motor over here, and one is sensory over here. So if you think about it, the middle cerebral artery, the most common artery injured in a stroke, is going to come from the middle and out to the side and up. So the middle, out to the side, and up on both sides. That's going to be occupied by the middle cerebral artery. The anterior cerebral artery is going to be, of course, the anterior cortex, like the frontal cortex, but also down in the middle area too. So if we have something going on in the feet here, the anterior cerebral artery is going to occupy all this area in here. So if we have something lower body, we're going to be thinking anterior cerebral artery, and that's going to be hitting right here. And so this is just a simple representation to help us understand some of the stroke symptoms anyways, some of the motor, some of the sensory, just based on where the arteries course and where the homunculus is laid out on the brain. So I just wanted to put that in there. Okay, so a few regions of the brain that we need to understand just generally. Name what each brain region does generally. So name the mechanism of each brain region. So the basal ganglia, what does the basal ganglia chiefly do? The amygdala, what does the amygdala do? What does the frontal lobe do? What is its responsibility in the prefrontal cortex? How about the hippocampus? What is the hippocampus responsible for? And what is the thalamus responsible for? So what do these brain structures do? So the first one, the basal ganglia, is responsible for motor control and initiation of action, and we can remember that from the basal ganglia in the substantia nigra deficiency in Parkinson's disease. So that's why they have that problem with motor control. So the basal ganglia, motor control and initiation of action. So fear, emotions, and memory, that's of course going to be the amygdala. Fear, emotions, and memory for the amygdala. The frontal lobe is going to be executive function, thought and higher brain function that humans have. So like the prefrontal cortex, that rationality, that's going to be all frontal lobe and prefrontal cortex. Memory is going to be hippocampus. So hippocampus mostly does memory. And thalamus is in the middle there where you have those descending and ascending fibers that are all crossing. So that's the classic major switchboard for motor and sensory tracks before it reaches the cortex itself. So that's like the major highway going from the spinal cord up into the cortex. So we'll go back to the vignettes. So this one I wrote, a patient comes in at 30 years old, stating he has been noticing some changes in his personality lately. He also states he's noticed some twitching of his face and odd movements of his arms. His mom told him to come in as she's worried he has a disease that runs in the family. What is it? What genetics is involved in this disorder? What is the triad of this condition? What will we see on MRI? And what is the best drug for the symptoms of this condition? So what drug? What are we going to see on MRI? What's the triad? What is this disorder anyways? And what's the genetics of this disorder? So this is going to be Huntington's. So Huntington's disorder, it's chromosome 4 and it's autosomal dominant. So that's the important things to know for the genetics. It's autosomal dominant. So that's why he's talking about his mom says the disease runs in the family. Autosomal dominant, chromosome 4. And the triad is MMM, motor, memory, and mood. So they're going to have impairments in motor with that chorea, memory impairments, memory changes, and mood, so personality changes. So he had personality changes here. Again, chorea is classic. On CT or MRI is more specific, is cerebral and striatal caudate nucleus impotament atrophy. So they might say cerebral and striatal caudate nucleus impotament atrophy. And again, this condition's fatal in about 15 to 20 years. And the medication that we can use is tetrabenazine. So tetrabenazine, and that's easy to remember, or helps you remember, the chromosome 4. So tetrabenazine on chromosome 4. So next one, a patient comes in. He's stating that he keeps shaking his hands for a while now. He says that this is worse when he tries to do certain things, like reach out to grab things, but it's okay when he rests. He is an alcoholic, and he states this is no good for him because the alcohol actually helps his shaking movements. What does he have? So he tends to drink more because now he's an alcoholic because he wants to use it to decrease his tremor. So what kind of problem does he have here? What is the genetics of this? What are the first and second line agents for this condition? So familial intentional tremor, when you intend to do something or start to move. Autosomal dominant, better with alcohol because it increases GABA, inhibitory neurotransmitter. And propranolol can be used. Propranolol is first line, and then primidone is second line. So you got to remember both sometimes, so propranolol and then primidone. Again, an action tremor, postural, not resting. Alcohol will typically make it better. So next patient is 65. He comes in with complaints of instability in his usual daily walks. You notice on physical exam, tapping between his eyes elicits a rapid and sustained blinking when you do that. You also notice on physical exam there's seborrhea on his head. What's the diagnosis? So he's having some instability in his usually daily walks that he didn't used to have. He's having, when you tap on in between his eyes right here, he does rapping and sustained blinking. You also notice there's seborrhea. So what's this diagnosis? What's the pathophysiology of this condition? What is the classic triad of this condition? And if you examine their brain post-mortem, what will you find on histology? So this is going to be Parkinson's. So remember, Parkinson's increased risk of seborrheic dermatitis, instability, as well as this called the glabellar reflex, when you're tapping on the nasal bridge there and you have that rapid sustained blinking. The pathophys is a loss of dopaminergic neurons in the substantia nigra. And you'll have bradykinesia, a resting tremor that gets better with movement. So this is better with movement as opposed to the postural tremor, the familial intentional tremor, and also rigidity. You'll also find Lewy bodies in the substantia nigra. So why do we add carbidopa to levodopa? So next question is, why do we add carbidopa to levodopa? What are the two adverse effects of this medication? And name the three most used dopamine agonists and when you would use them. So when do we use dopamine agonists in this patient? We said it was a decrease in dopamine. And how about anticholinergics? What's the principal reason we use these drugs? So we already know this and we described it in a different case for nausea and vomiting when we use the antiemetics. So same thing. So how about anticholinergics? What are the three dopamine agonists? Adverse effects of carbidopa and levodopa. So carbidopa decreases the peripheral conversion to dopamine, so more can cross the blood-brain barrier and less is converted outside and wasted in the systemic circulation. And this also reduces the amount of dopamine needed. So importantly to know, it has a wearing off effect, carbidopa levodopa does. So our goal is to minimize the use of it in many different ways. And this is why we have all these other medications for if they start to develop Parkinson's early, we can potentially start them on other medications to preserve this wearing off period. And nausea and vomiting is a notable side effect. So remember dopamine inhibitors by the antiemetics, prochlorperazine and metoclopramide. So remember nausea and vomiting because we're inhibiting that dopamine. So if we're increasing dopamine here, then we're going to get increased nausea and vomiting. So it's just the opposite of antiemetics. So increased nausea and vomiting because we're increasing dopamine from carbidopa, levodopa. And when we inhibit dopamine, we decrease the nausea and vomiting. The example is by the antiemetics here. And also think psychosis. So what is the mechanism of antipsychotic drugs? They're anti-dopaminergic drugs. So we're giving dopamine here, so we might have episodes of psychosis potentially. So that's just, it's not perhaps not as cut and dry as this, but that's an easy way to remember what these side effects of carbidopa levodopa are. So nausea and vomiting and potential episodes of psychosis, since it's the opposite of the antipsychotic medications. And the dopamine agonists are going to be BPR, that's how I remember them. BPR, bromocriptine, pramipexole, and ropinirole. So bromocriptine, pramipexole, and ropinirole, BPR. And again, our goal is to increase dopamine by decreasing the use of levodopa, carbidopa. So you want to use dopamine agonists if they're less than 65 to prolong, again, the time before we actually start the levodopa, carbidopa. The anticholinergics, TB is how I remember them. TB, that's trihexyphenidyl and benztropine. So anticholinergics, trihexyphenidyl and benztropine. So it's only going to help those tremor symptoms. So it's going to help decrease the tremor symptoms. So that's what our goal is for the anticholinergics in Parkinson's disease. It does not improve the bradykinesia as well. So next one, name 3 other classes of meds that can be used. So what are 3 other classes of meds that can be used? What is the side effect of tolcapone? 3 other meds and also tolcapone. So we can use amantadine, we can do COMT inhibitors, we can do MAOB inhibitors like rasalgiline and selegiline, and tolcapone is a COMT inhibitor, and that's hepatotoxic. So what disease is a progressive upper and lower motor neuron disease? So what disease is a progressive upper and lower motor neuron disease? What exactly will be spared in these patients? What is the most common presenting symptom in these patients? And how do we definitively diagnose these patients? So what is spared? How do they present? How do we diagnose? Upper and lower motor neuron, no sensory neurons. And also, 2 more questions. What is the only med proven to help these patients? And how do most patients die with this condition? So what is the mechanism of their death? So that's going to be ALS, amyotrophic lateral sclerosis, and that's also called Lou Gehrig's disease. What is held intact? Intact is going to be sensation. It's motor neuron disease. Also their eyes and anal and urethral sphincters, and also their sexual function is going to be intact. So sensation, eyes, anal and urethral sphincter, as well as sexual functions intact. Asymmetric limb weakness is the most common presenting symptom. Asymmetric limb weakness, and also bulbar symptoms and aspiration you'll find. So bulbar symptoms, they can't really swallow well, they can't chew well, and aspiration due to that. And we see a mixed upper and lower motor neuron disease in this. The med proven to help is Riluzole, and I guess it helps by 6 months. It accordingly helps by 6 months. And EMG is the definitive diagnosis. We can see an elevated CPK also in labs, but EMG is going to show a loss of innervation. And respiratory failure is how they die. So the diaphragm is a muscle after all. So if they're having motor neuron disease, respiratory failure. Or it could also be from aspiration, pneumonia, because they can't really cough it up. Okay, next question is, what is the triad of Tourette syndrome? So what is the triad of Tourette syndrome? How do we diagnose Tourette syndrome? What is the first-line management for Tourette syndrome? And how about the medical treatment for Tourette syndrome? So first-line management, different from medical treatment. How do we diagnose it, and what's the triad? So VMO, that's how I remember it, kind of like vastus medialis obliquus, but in this case it's verbal, motor, and OCD. So this is what these patients have: verbal tics, motor tics, and also OCD. And it's prior to age 18 at start. It's usually 4 to 6 when they start, but prior to age 18 is part of the criteria. And they have to have multiple motor and 1 or more vocal tics for at least a 1-year period. So over 1 year, motor, multiple motor, and 1 or more vocal tics. Again, first line, habit reversal therapy. Medical is the second line. You can use tetrabenazine, clonidine, guanfacine as well. But habit reversal therapy is first line for tic disorder. What is a brain disorder associated with spastic muscle tone and movement abnormalities, as well as postural abnormalities that have been there since birth due to hypoxia or other perinatal injury? So that's going to be cerebral palsy. So cerebral palsy, perinatal hypoxia, and it's going to be muscle tone, very spastic, and movement abnormalities. So next vignette, a patient comes in complaining that for the past 4 months since giving birth to her son, she has noticed a tingling, funny feeling in her legs at night that makes it harder to sleep. She states that the symptoms get slightly better when moving the legs during the night, but this is causing her much distress. What is her condition? What is this likely a deficiency of, which could give it away? And what is the treatment for this condition? So this is going to be restless leg syndrome, RLS, restless leg syndrome. It's typically due to a possible cause is iron deficiency. So if you have iron deficiency, that's a possible cause. It's after giving birth is a risk factor. And you just want to replace for treatment if the iron stores are low on labs. But you can also do dopamine agonists like BPR. We just went over bromocriptine, pramipexole, and ropinirole. Those are dopamine agonists that will help in this condition. Also gabapentin, gabapentin will help them sleep as well. So next one, a patient comes in complaining of ear pain on the right side that started 2 days ago that is pretty severe. She states that she also has been having a weird feeling of tastelessness, a dry eye that isn't getting better with eye drops, and she also reports she continuously feels like she's biting her inner cheek on that right side inadvertently. She is concerned. What is her diagnosis? So again, ear pain on the right side 2 days ago, pretty intense, tastelessness, dry eyes, biting of the inner cheek. What do you think is her diagnosis? What type of neuron disorder is this? And there's two. What is the health maintenance and treatment for this condition? How do we differ this from a more serious condition? Okay, so this is going to be Bell's palsy. So Bell's palsy, it's a lower motor neuron disorder, as we already said in the cranial nerve disorders. This is a cranial nerve 7 facial nerve palsy. You want to advise for management artificial tears and an eye patch at night to prevent for corneal ulceration and prevention. Remember we said cranial nerve 7 is what closes the eye, and cranial nerve 3 is what opens it. So cranial nerve 7, that's going to have a palsy. We can give prednisone, although this is self-limiting condition. We can give prednisone for this condition, and it's usually helpful if we give it earlier, within 72 hours of the onset of the symptoms. We could do acyclovir too, as herpes is a potential cause for this. And of course, how do we differ this from a more serious condition? Strokes will spare the forehead. So cranial nerve 7, Bell's palsy does not spare the forehead, so they won't be able to raise their eyebrows on one side, typically unilateral. So stroke will spare the forehead, important to make that differentiation. Patient comes in complaining of tingling in his feet of 2 weeks and occasionally dragging and tripping on his feet when walking. He denies any other symptoms or past medical history other than a fever and some diarrhea last month, but he states this is completely resolved now. What are you thinking of? So importantly, tingling in his feet for 2 weeks, that's getting worse. He results in dragging his feet, tripping when he's walking. He just had a fever and some diarrhea last month. What are you thinking? What are the 4 A's of this condition? What will be seen on CSF analysis? So some of these questions kind of give it away. What are the 4 A's? What will be seen on CSF analysis? What is the most common preceding factor to this disease? And what should not be given as treatment? So what should not be given as treatment? And what's the most serious complication? So what is the most serious complication of this condition? So that's going to be Guillain-Barre syndrome. Guillain-Barre syndrome, it's areflexic because it's an ascending polyneuropathy. Ascending, areflexic, ascending, afebrile, because they're not having a fever now, and an antecedent event. They had a previous fever and diarrhea in this patient, so that's Campylobacter jejuni. A previous bacterial infection is typically an antecedent event. Could be a URI, could be a GI pathogen or respiratory. And on CSF, we see that albuminocytologic dissociation again, more protein and no white blood cells. So elevated protein, no white blood cells. Like we said, Campylobacter jejuni, an important one to know, is the most common. And the mechanism is molecular mimicry, autoantibodies to the myelin sheath. We don't use steroids for this. So it's an autoimmune condition. You might assume that we would use steroids for this, but we don't use steroids. We use plasmapheresis or IVIG. So that's an important one to know, that we don't use steroids for GBS. And again, the most serious complication is an ascending to the point where it gets to the lungs and causes respiratory failure. So you can get PFTs in these patients. So ascending to the lungs is the most serious complication. Next one is a 40-year-old woman who comes in complaining of fatigue. It gets worse throughout the course of the day, and what really concerns her is that she's been having difficulty chewing and swallowing at dinner time, not in the morning though. She states there has been a seeing of doubles, but her pupils are equal, round, and reactive to light on exam. What is her diagnosis? So a few things. She's having fatigue. It's worse throughout the course of the day, and she's been having difficulty chewing and swallowing at dinner time, but not breakfast. She's seeing doubles, so she has diplopia, and her pupils are okay, equal, round, and reactive. What's her diagnosis? What is the pathophysiology of this condition? Very important to know. What gland is abnormal 75% of the time in these patients? And what would you think if the weakness got better throughout the day with repeated muscle use? And a clue, it's also associated with small cell lung cancer. So a few questions there for this condition. So this is going to be myasthenia gravis. It spares the pupils, and the pathophysiology is autoantibodies to the acetylcholine nicotinic receptors on the neuromuscular junction. So we're going to be exhausting all the acetylcholine in the synapse throughout the day, and it leads to that weakness. And especially since this lady had weakness with chewing and swallowing around dinner time, it's also going to lead to that bulbar weakness, those bulbar symptoms. So those are muscles that use up the acetylcholine as well. So like we said, ocular weakness for the ptosis that we can see, bulbar weakness that was in the vignette, and also the thymus is going to be abnormal. So we can do a thymectomy, which helps all patients. And we said another question was, what if it got better throughout the day with repeated muscle use? What might we think with the same vignette? We might think LEMS, Lambert-Eaton myasthenic syndrome. So Lambert-Eaton myasthenic syndrome, that's going to be similar, but it's antibodies against the calcium-gated channels that prevent the release into the synapse, not the acetylcholine receptors. So myasthenia gravis is acetylcholine receptors, so the acetylcholine, it's not getting to the other side of the synapse. For this, the calcium-gated channels are the problem, and we're not releasing the acetylcholine into the synapse in the first place. So it's a little bit different mechanism. However, in LEMS, it gets better throughout the day. And remember, this is associated with small cell lung cancer. So small cell lung cancer and LEMS are associated. Another few questions. What is the first test you should get in the outpatient setting? What's the first test you should get in the outpatient setting for this patient? How about in the ER when they're in a crisis with low O2 saturations and dyspnea? So how would you do it if they just showed up, you didn't know they had this diagnosis, and now they have low sats and dyspnea? What is the mechanism of action of the first line treatment? So how does the first line treatment really work when we give it? And what might you see in an overdose if you overdose them on this treatment? So a couple important questions here. So outpatient, you would get an acetylcholine receptor antibody test. So you get an ACH receptor antibody test. If it's negative initially, then you can get also the MuSK. So it's important to know that for myasthenia gravis outpatient, acetylcholine receptor antibody test, if it's negative, get the MuSK. And you can also get a chest x-ray too, like we said, for the thymus gland. And an EMG is the definitive test, which is most accurate. So the repeated nerve stimulation leads to that wearing off, and you can really see that you're having a problem with the acetylcholine in the postsynapse. So in the ER, you can do an ice pack test or an edrophonium for a quick assessment. So basically, the edrophonium is a quick, fast-acting acetylcholine esterase inhibitor that will help confirm the diagnosis. So it gives it a chance to build up the acetylcholine in the synapse and see if they get better from that. And if they do, you kind of have your preliminary diagnosis because you just gave them the acetylcholine esterase inhibitor, which blocks the acetylcholine esterase, that's trying to take out the acetylcholine from the synapse. So if you block that, you're helping build up more acetylcholine in the synapse. So that's going to help you. But the edrophonium, it only lasts for a short amount of time. So it's only really helpful for the quick diagnosis. So that's what you're going to do in the ER. You can do the ice pack test or the edrophonium test. And then you can do IVIG or plasmapheresis as well. So if long-term outpatient, you want to do those acetylcholinesterase inhibitors, the stigmines like neostigmine, ribostigmine. And again, those prolong the acetylcholine in the receptor. So that helps this condition. It blocks the thing that's taking the acetylcholine out, which is that ACE, that enzyme, acetylcholinesterase. So if you overdose on these stigmines, then of course you're going to have a cholinergic crisis because you're increasing that acetylcholine so much, and you can get the sludge effects. So the salivation, lacrimation, urination, defecation, GI, and also meiosis of the eyes, constriction of the pupils. If you overdose on the cholinergics. So next one's going to be a 28-year-old woman from Alaska. She presents complaining of a radiating shock-like pain that goes from the spine down her leg. She states this occurs when she flexes her neck down to her chest. She denies any trauma. She also states recently that her vision has been off and occasionally sees doubles. What diagnosis are you thinking of? So, a few things. 28-year-old female. She's from Alaska, a cold area. She has this radiating shock pain that goes from her spine to her legs, but it only occurs when she flexes her neck down. She's also been having visual problems and sees doubles, diplopia. What are you thinking of? What's the most common type and pattern of this disease? And what parts of the CNS are involved in this disease? What's the best test for this condition? So this is, and furthermore, for this condition, acute treatment is what? Prevention of relapse is what? And what is Uthoff's phenomenon? So if you know what that is, you know all these. What is Uthoff's phenomenon? So a few questions just to go through it again. What is the most common pattern? What part of the CNS is affected? What is the best test initially? Acute treatment is what? Prevention is what? And what is Uthoff's phenomenon? So this is multiple sclerosis. We saw many of those risk factors for multiple sclerosis. And this is Lermit's sign. Lermit's sign with that shocking pain when you flex the neck down. And it's most common in the colder regions, so Alaska. Relapsing and remitting is the most common pattern. It's an upper motor neuron disease that is autoimmune in nature, and it's demyelinating of the white matter in the brain and spinal cord. So it's upper motor neuron. So that's why it leads to that spasticity, because we're inhibiting the upper motor neuron, then we have uninhibited lower motor neurons. So we're going to have those problems with the spasticity there. So upper motor neuron disease, it's autoimmune and demyelinating of the white matter. So you might see an upward Babinski and hyperreflexia, which is consistent with our understanding of an upper motor neuron disease. The best test is MRI with gadolinium, importantly, with gadolinium. And what you'll see is hyperintense white matter plaques. So it's important to know hyperintense white matter plaques. And for acute management, methylprednisolone. And for chronic, glatiramer or beta interferon for long-term preventing those relapses. And you also should know worsening of symptoms with heat, such as sauna, hot tub, and shower. That's Uthoff's phenomenon. So they get worsening of their symptoms when exposed to these type of hot environments. So explain the Marcus gun pupil in optic neuritis. So what is the Marcus gun pupil in optic neuritis? How does that work? What is the most common primary CNS tumor in adults? And how about the most common CNS tumor in kids? So Marcus gun pupil, most common primary CNS tumor in adults, and how about most common in kids? So Marcus gun pupil, basically when you're doing that swinging flashlight test, the second pupil dilates because the optic nerve is slow, and the dilation responds to the previous impulse from the previous eye as if the light were not there. So it's really just less than normal pupillary constriction, since you'd expect a lot of constriction. So basically when you're swinging it from the good eye to the bad eye, you'd expect both to constrict. But when you get to the bad eye, it doesn't constrict or constricts less than normal because of the delay, because you have the optic nerve damage. So it looks like it really dilates. So that's the Marcus gun pupil. And glioblastoma multiforme. So glioblastoma multiforme, that's the most common CNS tumor in adults. And kids is the pilocytic astrocytoma. So that's the most common in kids, the pilocytic astrocytoma. So next one, a headache that wakes up the patient at night is concerning for what? Headache that wakes a patient up at night is concerning for what? CNS lymphoma is most commonly caused by what? CNS lymphoma. What is the biggest risk factor and is positive in 90% of these patients? So CNS lymphoma caused by what? What is the biggest risk factor and is positive in 90%? So you want to be thinking of a brain tumor, of course, if it's randomly waking a patient up at night. Non-Hodgkin's lymphoma is the most common cause of CNS lymphoma. So remember, non-Hodgkin's lymphoma goes to other areas around. So it disseminates more around the body than Hodgkin's lymphoma does. So non-Hodgkin's lymphoma is brain lymphoma. And EBV is positive in 90% of these patients with CNS lymphoma. So it's important to know EBV in 90% of the patients with CNS lymphoma. So next one, a tumor seen on the lining of the fourth ventricle. What would you think it is? So a tumor seen on the lining of the fourth ventricle, what would you think it is? So what cells are even on the fourth ventricle? It's important to know. Ependymoma. So ependymoma. So ependymoma, these are the cells that line the ventricles and spinal cord. They secrete and they basically manage the inflow and outflow of CSF. So that's what you see. So next one. A 75-year-old male in a nursing home with no pertinent past medical history started taking Benadryl 2 weeks ago for allergies. He has developed acute onset of confusion. What is this? So he's been taking a lot of Benadryl. What is this? What are the 3 proposed pathophysiologic mechanisms for Alzheimer's? What will be seen on MRI for Alzheimer's? What are some of the agents used in this condition? And what is the chief symptom noticed by the family? So a few questions. 3 pathophysiology mechanisms of Alzheimer's. What do you see on MRI? What are the agents? And what are the chief symptoms noticed first by the family? And of course, what is this guy up here experiencing? So he's experiencing delirium. So delirium, he's had acute onset. He's had no past medical history. He's 75 in a nursing home. And he's been taking a lot of anticholinergic medications such as Benadryl. So Benadryl has a lot of anticholinergic properties, which is a risk factor, especially in elderly in the nursing home, so delirium. The 3 pathophysiology mechanisms, one is going to be tau plaques, neurofibrillary tangles that congregate in the brain. So tau plaques is one of them. Another is amyloid beta protein deposition. These were previously called senile plaques. So amyloid beta protein deposition, senile plaques. And then, of course, acetylcholine deficiency. So that's why you don't want to use Benadryl long term. So if you're using a lot of that, you're having decreased acetylcholine. Acetylcholine is between the synapse. It's helpful to transmit neuroimpulses. So acetylcholine deficiency, long-term, no good. That's also a proposed mechanism of dementia. What will you see on MRI? Cortical atrophy. So cortical atrophy. And medications you can use, a few are memantine, donepezil, tacrine, rivastigmine, and galantamine. So memantine, donepezil, tacrine, rivastigmine, and galantamine. These are all medications we can use in that. And what does family notice first? Memory loss and executive function decrease. So unable to have a good working memory, accomplishing tasks at the same rate, and also, of course, short-term memory first, and then develops into the long-term memory that they start to lose. Okay, I think we'll stop there, and then we'll continue for a third and final neurology questions video.